colleagues, friends, ladies and gentlemen. My name is Dr. Chaudhary, and on behalf of the NAFLD Conclave and the Indian National Association for the Study of Liver, I welcome you to this fourth conclave. That is the fourth year of the conclave, and this happens to be the fifth webinar of this year. As we had promised last time, this year, this particular webinar is dedicated to very practical managements of making diet and exercise work for NAFLD patients. You know, all of us seem to know that it's something to do with the lifestyle, but that's the part which is most ignored, be it in our prescription or be it in our prescribing manners or be it in the guidance that we give to patients and as a part of a general public policy or lifestyle. But that's where the fulcrum, the crux of the matter is. So we are too obsessed with medicine. This webinar is all about trying to make diet and exercise work for your NAFLD patients. And we have very eminent people to take us through this. They'll be introduced to you. But let me first welcome the three chairpersons, three hepatologists of great eminence. First is Dr. Y.K. Chawla. Dr. Chawla doesn't need any introduction. He was the head of hepatology and thereafter the director at PGI Chandigarh. And he's one of the best known names in this field in the world. Then we have Dr. Anil Anand, AC Anand, who had a wonderful, brilliant career as a gastroenterologist in the Defense Forces. He retired as a Vice Admiral. And at this point, he's serving as a professor of gastroenterology at hepatology in Bhubaneswar in Kalinga Institute. He's, of course, a prolific researcher and a writer and a very cerebral person. And the third is none other than Dr. Kaushal Madan. Dr. Kaushal Madan has had many roles and hats, been a very great academic. At this point, he's in a Max Hospital as the Chief of Hepatology, but more importantly, he's the Secretary General of the Indian National Association for Study of Liver. So the three chairpersons will take us through, and we have a galaxy of wonderful speakers, and I'll now pass it on to them. Just one point that I had to make. We have tried to take your feedbacks and keep this session as much as possible in a case-based format. So most of our discussions will be revolving around case examples and what we have learned or what we can offer by way of learning. And at the end of it, I'll take the liberty of making a 5-minute presentation on certain hacks and strategies and charts and tricks or links that you can share as a part of your practice when you're guiding patients with NAFLD. So with that, over to Dr. Chawla, Dr. Anand, and Dr. Kaushal.
Thank you, Gaur. It's very interesting, going to be very interesting today, and we have some important points to be discussed. And the first speaker to us is Professor Ashish Kumar, who has already been introduced to you by Professor Gaur Chaudhary. I believe Arun Sanyal has not yet joined us, so I'll request Ashish to give the first talk. So Ashish is going to talk to us on the role of diet and NAFLD.
Can I, in the meantime, just put things in perspective because Dr. Arun Sanyal has not joined. So in today's webinar, we thought of 3 or 4 aspects of lifestyle. As we know, one of them is diet, which forms a very crucial role in how to shed weight and how to reduce fat. The other is going to be the role of exercise. How do we do it as a part of a program or as a part of our day-to-day lives? And the third, which is a very new emerging concept, is the role of sleep and the circadian rhythm. And does it have a role to play in fatty liver disease? So much of our discussion will be on these 3 lines. Obviously, our opening issue would be diet. And with that, we have Dr. Ashish to first address us on the role of diet.
Thank you. Good evening. Good evening, ladies and gentlemen. Thank you, Dr. Chawla, for the introduction. And at the outset, I would like to thank Dr. Chaudhary for inviting me here. So can I have my slides? Can I have the first slide? So I bring you greetings from Sir Gangaram Hospital. So I'll be talking about role of diet in NAFLD. So I'll directly come to the case. Yeah, so this was a 47-year-old gentleman from Delhi, a Punjabi guy who was a businessman. He had an automobile accessory shop and he had a sedentary lifestyle. So he would sit in his shop from 9 a.m. to 9 p.m. And he said that he did not have any time for exercise. He had mainly vegetarian diet, although he was non-vegetarian, but most of the time he consumed vegetarian diet and he was non-alcoholic. So he presented with chief complaints of fatigue for last 3 months, pain in abdomen, which was mild and mainly located in the right upper quadrant for last 1 month. So these were his complaints. He was diagnosed to have hypertension about 1 year ago, for which he was on medications, but he would often skip those. And on examination, I found only hepatomegaly and no other positive finding. His anthropometric data was that his height was 5 feet 8 inches, weight was 90 kg, and the BMI was around 90. So his investigations, his hemogram was unremarkable. In his liver function test, only AST and ALT were elevated 2 to 3 times. In his kidney function test, uric acid was slightly elevated. Hepatitis B and C viral markers were negative. Thyroid was normal. HbA1c was slightly elevated in the pre-diabetes range, that is 6.2. Ultrasound showed a grade 2 fatty liver, and his fibroscan showed liver stiffness of 8.8 kilopascal, and the controlled attenuation parameter, that is fat content, 358, which was high. So we made a diagnosis of non-alcoholic steatohepatitis with liver fibrosis, hypertension, liver fibrosis because of slightly elevated liver stiffness measurement here, hypertension, pre-diabetes, obesity, and hyperuricemia. So what we prescribed was weight reduction through lifestyle modification, dietary counseling, exercise, and few drugs. These were the drugs. And so I began with the dietary counseling. So on asking him, he mainly said that he does not consume any junk food. He takes only food prepared at home. So on digging further, I wanted to ask what exactly he consumed. So this was the diet he told. So in the morning, he used to take tea with 2 teaspoonfuls of sugar and 2 biscuits. Breakfast was aloo paratha, 2 little curd and 1 sweet lassi. Lunch was basically 2 chapatis, rice, dal, and curry. Evening snacks he would have in his shop only. That was 1 tea and a samosa or bread pakoda, whatever was available nearby his shop. Dinner was same as his lunch, chapati, rice, curry, and dal. And at bedtime, he would take 1 glass of milk with sugar. So this is the diet he used to take, and this is what the diet most of the North Indians would take, and we all would relate to this diet. So there's no extra junk food like pizza, burger, or anything else. So I would now, there's something wrong in this diet. So I would like an audience to respond to this. So I want the audience poll to run now. Can audience poll come? So my question is, what is wrong? Is there too many calories, too much of carbohydrate, too little protein, fiber, and all? So can we have the result?
Just give me a moment, please.
Yeah. Okay. So most of them said that there are too many calories and too much of carbohydrate and too much of fat. But I'll tell you, whatever the response you all gave, all of them are correct. So can I have my slides back? Okay. So all the responses were correct. In fact, he was consuming too many calories, too much carbohydrate, too little protein, too little fiber, and too much of fat. Regarding fat, I'll come to it. So what is the calorie content of his diet? So in the morning, he was taking approximately 130 calories with 80 calories of biscuits, 30 of the sugar. Breakfast, because of the aloo paratha, it was about 785 calorie, lunch 664 calorie, evening snacks 410, again dinner of the same 664, and bedtime 190 calories. So total he was consuming 2843 calorie. And this is too high for a sedentary individual. According to the dietary guidelines, for a sedentary individual of between 31 to 50 age, that dietary advice is to consume 2200 to 2400 calorie, and he was consuming 400 to 500 calorie more than what is required. Now let us look in little more detail of his calorie breakup. So he was consuming 60% of the calories in form of carbs, 27% in form of fat, and 13% of protein. The recommended carbohydrate intake should be 50%, 30%, and protein 20%. So what he was consuming as fat, although percentage was okay, but the amount was high. Regarding protein, the percentage was also low and the amount was also low, and carb was way too much. Amount as well as the percentage was high. So he was consuming about 432 grams of carbohydrate. So let us see what is the effect of carbohydrate. So if someone consumes just 0 to 50 grams of carbohydrates, this is what people prescribe in ketogenic diet. It leads to ketosis and fat burning. So it may be helpful for people with insulin resistance. If we increase the carbohydrate to 50 to 100 grams, this is good for people who are not exercising, and it is easy to keep a weight off if you're consuming this much. For 100 to 150 grams is okay for those people who are active and healthy. But if carbohydrate content is 150 to 300 grams, it is slightly higher than what is required, but it could be okay depending on your activity level or insulin sensitivity. But anything more than 300 grams, this is far too much, and this drives the insulin resistance. And our guy was consuming about approximately 432 grams, which was too much. So for a normal healthy individual, if he's consuming 2000 kilocalorie diet, approximately half of them should come from carbohydrate. So approximately 250 grams is an okay amount. But our patient was consuming far too much. But not only the amount of carbohydrates, the type of carbohydrate is also important. So there are 3 types of carbs. One is sugars, the other is starch, and third is fiber. Sugars are simple sugars like glucose, sucrose, fructose, which are very easily digested and absorbed. Then starch are cereals and potatoes, and examples of fibers are vegetables and whole grains, which are very difficult to digest and absorb. So what happens if we consume excess amount of sugar? So sugar in the form of sucrose or fructose containing sugar, if we consume excess amount, and if we are not able to metabolize it rapidly, or use it rapidly, then it is all converted to fat. And this is called as de novo lipogenesis. And this accumulates in the liver in the form of triglycerides. It causes liver toxicity in the form of steatohepatitis. And it is also exported away from the liver and goes to the various parts of the body, including heart, and it poses a risk of cardiovascular diseases. And there have been multiple reviews and studies which have proved that fructose and sugars are the main mediators of non-alcoholic fatty liver disease. Animal studies have shown that even a small amount of daily intake of sugar-sweetened beverages can lead to fatty liver. Sugars, and in the Freminger heart study, it was shown that those people who consume a lot of sugar sweetened beverage were at higher risk of fatty liver disease. And it was also shown that if you replace your alcoholic beverage with sugar sweetened beverages, the result is same, and you will have got same amount of fatty liver. And multiple meta-analyses have also been done, which have shown that sugar is the driver for your fatty liver. And if you, it has got dose-dependent effect. The more you consume sugars beverages, you have more chances of having fatty liver disease. And even in animal experiment, it has been shown that it is high sugar but not high fat diet which leads to hepatic fatty deposit. So in this animal experiment, there were two groups of animals. One was given high sugar diet, one group were given high fat diet. Those animals which received high sugar diet had increased weight, increased leptin content, increased insulin, and various upregulation of transcription factors. But those animals which received only high fat diet, only the weight was higher and leptin was higher, but there was no such changes in insulin level or transcription factors. So it is the sugar which mainly drives the hepatic metabolism. And what is the amount of sugar which is recommended? According to American Heart Association, the men should not consume more than 50 calories of sugar, that is 9 teaspoonful, and women should not consume more than 100 calories, that is 6 teaspoonful. And if you have diabetes, metabolic syndrome, fatty liver, obesity, it is better to avoid totally, or at least less than 5% of your total calorie intake should be in the form of added sugar. Coming to other types of carbohydrate, that is cereal, starch, and vegetables and whole grains. So when we are discussing this type of carbohydrate, we should know about glycemic index. Glycemic index is the amount of glucose which is raised after consuming that amount of carbohydrate. So there are two types of carbohydrate. One which causes a rapid rise in glucose level and consequently insulin level, and one which is leads to a slow rise in glucose level in the blood because it is very slowly absorbed. So the rise in the insulin will be low. So what is the effect of high glycemic index food? If you consume a lot of high glycemic index food, the sugar in the blood will rise rapidly. And with the consequent increase in insulin level, it will fall down fast. And at the point where the sugar level in the blood will decrease, you'll feel hunger pangs, and you'll again consume high glycemic index food. So you'll end up eating much more. But if you consume a low glycemic index food, the energy would be released slowly, the carbohydrate or glucose will be released slowly, and there'll be no ups and downs in the sugar levels. So you'll feel fuller and you will eventually eat less. So it has been shown by animal experiments that those animals which have been given rapidly absorbed carbohydrate as compared to slowly absorbed carbohydrate, they developed weight gain and also had fatty liver as compared to those who had slowly absorbed carbohydrate. And this has also been shown in meta-analysis that low glycemic index diet is a good intervention when we are trying to reduce weight. But not just glycemic index, glycemic load is also important. So what is glycemic load? So for example, watermelon, it has the glycemic index of 72, which is quite high, and white rice, which is a glycemic index of 58. But what we do, if we consume 120 gram of white rice, the carbohydrate load would be 33.5 and the glycemic load would be 19. While 120 gram of serving of watermelon will only have 9 gram of carbohydrate. So glycemic load will be less, that is 6.5. So for same amount, that is glycemic load of 19.4, one serving of white rice would be equivalent to 3 serving of watermelon. So actually, even though glycemic index of white rice is lesser than that of watermelon, but because there's a lot of carbohydrate, the load is much important. And this is categorized into 3 categories. So anything which is more than 20 of glycemic load is high, moderate is 11 to 19, and low is 0 to 10. So what are the diets? For example, white rice has got very high glycemic index, 27, white pasta, French fries, baked potato, and all this. Moderate is whole wheat pasta, brown rice, sweet potato. And vegetables are obviously have got low glycemic load and they are much better. So so when we advise, so instead of using maida or the usual atta or the wheat flour, it is much better to use whole white wheat flour or a multi-grain flour, because these have a low glycemic index as well as low glycemic load. Similarly, rice is compared to white rice, brown rice is much better, and even better is the black rice and the red rice, because they have got low glycemic index and they have much higher fiber content. Coming to the fat, so when we are buying cooking oil for ourselves, what are the factors we should look when choosing a cooking oil? We should look for saturated fat in the labels, trans fat, unsaturated fat, especially MUFA and PUFA. MUFA is the monounsaturated fatty acids, and polyunsaturated fatty acid, omega-3 and omega-6 ratio, cholesterol content, smoking point of the oil, and whether the oil is refined or cold pressed. So without going into much detail, I would advise you that you buy oil which has got saturated content of less than 10%. Trans fat should preferably be 0, because multiple studies have shown that it is bad for health. Monounsaturated fatty acid, and the saturated should be replaced by both MUFA and PUFA, and of them MUFA is better. And among the omega-6 and omega-3 types of PUFA, omega-3 is much better. Cholesterol content should preferably be 0 or as low as possible. We should check the smoking point of oil, that is at which temperature it becomes bad. And if we have to choose between refined oil and the cold pressed oil is much better because it has got better content. But when we are talking about fat, it is not just fat. We have other fats in other food items also. So we should avoid trans fat totally, saturated fat as much as possible, and we should eat unsaturated fat much more. For example, avocados, fish, cold water fish, olive oil, and the nuts. So when choosing oil, it is much better to have olive oil.
Sorry to interrupt. I think you'll have to wind up soon.
Yeah, I'll do that. And canola oil or the safflower oil are much better. And there's been an interesting study which showed that cooking oil also leads to change in the glycemic response of rice. So this was an interesting study where they chose 3 types of rice, they chose 4 types of cooking oil, and when was the cooking oil added, and they showed that a red rice when cooked with rice bran oil was much better as compared to other cooking oil and other types of rice. Coming to the protein, although the data is limited, it is recommended that 20% of calories should come from protein. This is 1.5 gram per kg. And the best source is either fat and dairy or soy protein. And protein increases the satiety and also makes us full. And so we consume low calorie because of protein. So coming back to our patient. So first, the dietary prescription we gave is to reduce his calorie content from 2,800 to 2,000 calorie. And also from 60% of carbs, which he was consuming, we reduced his carbs content to about 50%, only 1,000 kilocalorie, that is 250 gram. We reduced the fat amount, we increased the protein amount. And apart from dietary counseling, we gave him various drugs like saroglitazole, vitamin E, telmisartan for his hypertension, and folic uric acid, febuxostat. And we ensured that he came for his regular follow-up visits, regular counseling, and periodic blood tests were done. And most important thing, we tried to ensure that he adhered to his diet. And at 6 months, his weight was down from 90 to 81. His BMI reduced to 27. AST and ALT became almost normal. Uric acid came down to normal. And HbA1c also normalized. Ultrasound now showed a slightly less grade of fatty liver. And his CAP also came down. And the most important thing is his fibrosis level also came down from 8.8 to 7.3. So another audience poll here. So what led to his improvement in liver fibrosis? Is it weight reduction, vitamin E, saroglitazole, or is it just a lab error? So can I have the poll again? So yes, everyone is right. His weight reduction was the main driver of improvement in liver fibrosis. Can I have my slides back? So this was also proven by one of our own study where we gave saroglitazole to about 100
Can we skip this? I think we are running well
okay.
behind time, Ashish.
So I'll just
summarize. Yeah.
So this is my summary slide. This is the dietary recommendation for non-alcoholic steatohepatitis. We should reduce the calorie diet to about 7, so that the person achieves 7 to 10% of weight loss. And for this, we have to reduce the calorie content by 500 to 1000 calorie. We should try to adhere to low carb diet. That is 50% of the calorie should come from carbohydrate, not more than, and of which the added sugar should be as low as possible. And so if we are buying any food from the store, we should check the label as how much of the added sugar it has. The fat from the diet should be about 30%. And we should try to give 20% of protein. That is 1.5 kilogram of protein per kg body weight. Avoid fructose containing drinks. Substitute saturated fatty acids with poly or monounsaturated fatty acids. Prefer oil which has more health benefits. Increase the soy and protein content of the food and increase fiber intake. And most important is ensure adherence. So this is my summary slide. And with this, I thank you for patient hearing. And I would love to have questions.
Thank you, Ashish. I think Gaur, since Dr. Arun Sanyal has come, would you like
So
him
we can formally welcome Arun to the group. Arun, we started off without you.
Hey,
so
good morning. Good morning. Sorry.
Good morning.
No, you know, the time changed at midnight here. Because
yeah, I know, but you know, when you are woken up suddenly in the morning, early morning, you get up remembering your sleep. Was it a nightmare or a pleasant sleep?
Well, it was Sanjit's form.
Okay.
I will leave the rest to you to imagine.
Okay, fine. So I have more or less outlined what we are going through. So we had our opening batsman, Ashish.
And you also have to remember that it woke up my wife as well at 5 a.m.
So a bit of a nightmare. Never mind.
So Sanjit owes me now.
Okay. So Ashish, thanks a lot. I think that was a very beautiful talk. I wish we had a full 1 hour to discuss it. You have done your research very well, as you always do. Very enlightening talk. Over to the chairpersons. We go on to the next, please.
Right. So thank you, Ashish, for that wonderful presentation and emphasizing the fact that you have to reduce the calorie intake. And now to debate you on whether it's the low carb diet or low fat diet which would help reduce enough calories in patients of NAFLD, we have Dr. Eileen Kande. She's the head of department and dietetics, Department of Nutrition and Dietetics at Sri HN Reliance Foundation Hospital and Research Center. Dr. Eileen, please.
So, so you want me to begin with it? I thought Dr. Ashish was beginning with the carbohydrate part.
So I already made my point that
you made your point. Okay.
Yeah, we have to reduce the total calorie as well as the carbohydrate content, which is much high in the Indian diet, which is about 60 to 50 to 60%, which will bring down to less than 50%. That is what my point.
So the sugars and the parathas and the chapatis are what he thinks are the carbs.
Okay. Yeah. So I hope you all can see my slide share. And I'll start. Basically, we are going to be talking about fat and what you need to know about fat versus the carbs that is given in the diet. Now, there is one thing which I would like to, actually question is low carb diet to treat a non-alcoholic fatty liver disease. Does it make sense? And yes, for some reason, this is not moving. Okay. Okay, sorry about that. Okay, so does it make sense? So why is having much fat in the liver a bad thing? So most individuals with NAFLD have an increased abdominal fat, which we all know, insulin resistance, triglycerides, cholesterol, and they may have other comorbidities like hypertension or type 2 diabetes. So I'm sure by now you have guessed it right, that it might be that NAFLD is caused by eating too much of that, or it is caused by eating too much of the wrong things. So it may not necessarily be only the fat. So however, there are increased dietary fat consumption might play a causative role in the NAFLD. We have all read about it, we know about it. However, there are studies that have shown that only 15% of the liver fat is actually derived from dietary fat. Now, adipose tissue is a major source of fatty acids found in the liver, and the peripheral insulin resistance, increase of fatty acids in the liver or the adipose tissue is all because of basically a lot of underlying other causes. And there could be even very low density lipoprotein. So directly fat as a cause of NAFLD could be something that we need to ask ourselves. And there are various studies which suggest that it is also the weight loss that is beneficial with the patients in FALD, and not necessarily only the reduction of carbohydrates. So when you tell somebody to lose weight, in the real world, it's very limited because it's not very easy. We understand that, because lifestyle modification is, yes, the basis of calorie reduction, and which is achieved. But what happens in most of the patients, you find the adherence to the diet or to the weight loss is very limited. People find it difficult and they struggle to maintain their weight loss. So what is the actual solution to the NAFLD issues? So of course, the mainstay of the therapy in NAFLD is weight loss, dietary modifications. But when we talk about diets, you all may have heard of various types of diets that are there, and the question comes, are there some diets better than the others? Okay, so what are the different types of diets that we are looking at in the market, or in the, in what people are doing? So it's become like one social thing, when you go for your kiddie parties, like, oh yes, what diet are you following now? Are you following the low carb diet? Are you following low fat diet? Are you doing keto? Are you not doing keto? Or if she's doing keto, even I want to do keto. So, there are so many diets, the DASH diet, now Mediterranean diet, which is like so much talked about. But in India, how much can we actually follow the Mediterranean diet type? So that becomes a question. I was trying to look at a lot of scientific data which talks about fat, and whether actually reducing a lot of fat makes a difference in the diet. And there were many studies which showed that it is not only the amount of fat that you eat, but it's also the kind of fat you eat. So if you look at the modified Mediterranean diet, if you look at the fat percentage, which is 45% high in MUFA fat. So it's not that they have removed the fat. Fat is there. They have also tried to see whether fat sources, adding extra virgin oil makes a difference, or adding rapeseed oil makes a difference, or adding other kind of oils makes a difference. So these are some of the studies which shows that, adding omega-3 fatty acids, which is also a fatty acid, makes a difference to NAFLD. Now, what is the problem in India? So fats and fatty acids in India, is it time for us to seriously introspect and think that, are we using the right oil, or are we using the right methods of cooking for oil? And one of it, which comes out very strongly, is the effect of heating, reheating of fats, and that are used mostly in our cooking. So that is something where you got to look at. Now, when I talk about the quality of fat, we say that you have to give good quality fat. And when we talk about good quality fat, we talk about the omega-3, talk about vitamin E, role of vitamin E, that's a fat soluble vitamins. And we talk about vitamin D, again, it's a fat soluble vitamin. So when you're talking about good quality fats, you also talk about the other aspects of fat. Now, before I could end my talk today, I would just like to ask everybody one question, that we have, our macronutrients are just three: carbohydrates, proteins, and fats. Now, when you talk about removing one, that is your carbohydrate from your diet, or reducing your carbohydrate from your diet, what are you left with? You're left with two main macronutrients. That is your fat and your proteins. Now, if I go by what Dr. Ashish has to say, that proteins have to be 20% of your total calories. What remains is fat. So then how are you going to feed the people? How are you going to feed the person whom you're trying to advise a diet? So are you going to say that you have to add fat? Because if you remove carbs, you restrict proteins to some extent, then what remains is fat. So when we actually talk about the dietary part of it, we have to remember one thing, that when we talk about carbohydrates in the diet, we have to talk about carbohydrates, which is like bound with fiber, bound with vitamins, minerals, and what we have to remove is only the refined sources of carbohydrates. We need to keep carbohydrates, because if this person is already sarcopenic, you may land up making this person even more sarcopenic. When you try to reduce your weight with removing lots of carbs, what will happen? The body will start using proteins as its source for energy. And what happens to that? Because you're using proteins as your source of energy, you start losing your muscle mass. And that's when you get more sarcopenic. So when I say that you have to have a balance, it means that do not remove too much of your carbs. At the same time, the total calorie consumption is very important. Like what is given is what you take a history, you understand that yes, this person is eating up to 3,000 calories. But does that person actually require 3,000 calories is the question. So how to find out how much the person requires? Because everybody's requirement is different. So first of all, the first step of doing a proper diet is find out his actual consumption that he would be requiring for his daily expenditure. So in the total actual expenditure, if he is consuming, if he requires 1800 calories per day as a total energy expenditure, you calculate backward, calculate from that. So if you say 50% of the 1800 calories, then the remaining is divided into fat and protein. So with this, I would actually want to ask you all one more question again. A low carb diet to treat non-alcoholic fatty liver disease, now does it make sense? Thank you.
Thank you, Dr. Eileen. Dr. Ashish, would you like to respond? Maybe a minute?
Yeah, so I think both of us said the same thing. I did not say to remove the carbohydrates totally. I just said that what we are actually eating is too much of carbs. Like the patient I showed, he was eating about 60 to 65% of his calorie intake in the form of carb, and his calorie content was also too high. That was eating approximately 3,000 calorie. So what we did, we brought down his calorie content to about 2,000 according to his activity level, and we brought down his carbohydrate content to 50%. 50% is what is actually the good balance, and the rest of the amount was the rest of the 50% we divided equally into protein and the fat. So this is what we said. So from too much of carbs, bring down to 50%. I'm not saying to bring down to too low.
Yeah, so when we talk about keto diets, basically we are actually bringing the carb downs to very, very low, less than 100 grams. So that's the point which we should be able to counsel the patient well as to what is the low level of low carbs that we are looking at. Thank you.
So when we are talking about keto diet, this is a different ball game, because then we are depending on the ketones, and so this is different. But in a usual diet, when we prescribe to an NAFLD patients, we just advise him to reduce the calorie content and the carbs to about 50%.
Thank you, Eileen, and thank you, Dr. Ashish, for giving us a very good, interesting debate on whether the carbohydrate or fat, which is more important. I'm sure there will be many questions on this, because finally you have said the same thing and made it into form of a debate. We now move on to the second aspect of lifestyle modification, and that is the exercise. And to give us an overview of this is Dr. Charles Paracle. He is the Senior Consultant Gastroenterologist and Hepatologist at Aster Medicity Hospital, Kochi. Very popular and very, very innovative gastroenterologist, and he is going to talk to us exercise for reducing NAFLD.
Thank you, Professor, and for that kind words. And respected persons, teachers, senior consultants, and friends, exercise has got pleiotropic action in non-alcoholic fatty liver disease. And as clinicians, we have to learn to incorporate it into our treatment algorithm of NAFLD. Let's go through a few case scenarios. We have a 58-year-old banker by profession who has got metabolic syndrome, had a recent PTCA, has got osteoarthritis, is obese with a BMI of 32.5, and is referred to you for evaluation of grade 1 fatty liver on ultrasound. You find that he has got a deranged LFT, platelet count is 1,65,000. You rule out secondary causes, and you make a diagnosis of non-alcoholic fatty liver disease. You state the disease and find that he has got significant fibrosis. A second case that we commonly see in our practice is a 32-year-old IT professional who comes for his annual checkup. You find that he has got a impaired fasting glucose. His triglycerides are 278. His uric acid is 8.6 milligram %. His SGOT is 76 and his SGPT is 98. And his USG shows a grade 2 fatty liver. The patient has no comorbidities. You rule out his secondary causes, make a diagnosis NAFLD. And these are the two common scenarios we see in our clinical practice. And let us see how we can incorporate exercise into the treatment algorithm. And before I go further, can I have my questions? Sorry, I did not take the questions. So this is the first question to you. Both aerobic and resistance exercises produce significant reduction in intrahepatic triglyceride level. Is it true or false? So, you've got different types of exercises, aerobic, resistance, high intensity, interval training. So do they all produce same amount of reduction in intrahepatic triglyceride level, or is there any difference? Can I have a second question? So second question, vigorous exercise without dietary restrictions lead to significant weight loss and improvement in NASH score and fibrosis. Is it true or false? So can you achieve significant weight loss and improvement in inflammation and fibrosis with vigorous exercise alone without associated concomitant dietary restrictions? So we'll come back to the answers later. Can I go back to my slides, please? So lifestyle interventions in the form of diet, physical activity, and exercise leads to significant improvement in NASH. You can achieve about 64% improvement in NASH score, as well as 50% improvement in fibrosis. And you should know that it's much more than what is achieved by the newer drugs in phase 3 trials. But the problem is here, only 10 to 20% of your patients in clinical practice achieve more than 10% weight loss. So you have to know how to incorporate it into your clinical practice and how to get your patient to adopt and adhere to it. So sedentary behavior, low physical activity, and poor diet, all the three hits together causes metabolic syndrome. And studies have shown that sitting for more than 3 hours a day increase all-cause mortality by more than 1, with a relative risk of 1.30. And we also know that each sedentary hour leads to 1.15% increase in intrahepatic triglyceride level. And the study by Healy and colleagues showed that interruptions in sedentary time is beneficial for weight control, glucose reduction, and triglyceride reduction. And you can incorporate interruptions in sedentary behavior to complement your physical activity and exercise guidelines. So that's the first step in your management of your patient NAFLD. Your obese banker, who is probably sitting throughout the day in his office, you can ask him to interrupt, stand up every hour, ask him to use an app or a gadget that reminds him to stand up every hour, take a few steps, so that interrupting the sedentary time will complement the physical activity and exercise guidelines. Same goes with the IT professionals who sit throughout day in and day out in front of a computer. Ask them to keep reminders so that they get up every hour and take a few steps. And that means a lot to the improvement in intrahepatic triglycerides and fat. Now coming to physical activity, various guidelines are recommended that you should have at least 150 minutes of physical activity per week or 10,000 steps per day to reduce the metabolic risk factors. And this study by Halworth and colleagues from Newcastle has shown that daily physical activity is significantly less in patients with NAFLD. And the same group also showed that if we have short bouts of physical activity, it can be as good as long bouts of moderate intensity exercise. So you're coming back to your obese banker who's got coronary disease, got osteoarthritis, who is not able to do long bouts of moderate intensity exercise. It's a good news for him. He can do short bouts of physical activity. Walk a few minutes, walk for 3 to 4 minutes at least throughout the day. You can split it into short bouts of physical activity throughout the day. So at the end of the day, you achieve around 40 to 45 minutes of physical activity. That's a good news for the banker with poor cardiovascular reserve. And coming to exercise, exercise has shown a modest but clinically meaningful improvement in fat. You can get about 20 to 30% relative reduction in fat with exercise alone. But if you combine exercise with diet, and if you can achieve a 10% weight loss, then you can achieve as high as 80 to 100% improvement in fat. And how does exercise act? Exercise acts mainly by improving the insulin sensitization. It reduces the visceral lipolysis. In the liver, it reduces de novo liposynthesis. It increases the beta oxidation of free fatty acids that enters the liver. And it also increases the secretion of VLDL by the liver. So free fatty acids that comes into the liver gets oxidized and more gets secreted out as VLDL. So it gets deposited in the liver. So it mainly acts by increasing the insulin sensitization. And to incorporate exercise into algorithm, you should know what type of exercise to use, what dose of exercise to use, and how to practically implement it. And let's see what the data says. This slide summarizes all the prospective studies that are done with exercise in NAFLD. And this from the ILTS position statement on NAFLD that was published in 2019. And you can see that most of the studies showed significant reduction in intrahepatic triglycerides, and that was independent of weight changes. But problem with all these studies is that these are small number of patients, short duration, 6 to 12 weeks, and they looked only at fat. They do not look at inflammation or fibrosis. That's the drawback of all these studies. And this is a meta-analysis by Cazzagoni that was published in 2017. Again, 564 patients in NAFLD divided into two groups, the intervention arm and the control arm. And they showed that the exercise significantly reduces fat independent of the weight class. Sorry. Now coming to what type of exercise you use, we know you have got aerobic, you have got resistance, and you have got high intensity exercises. This is a study by Johnson and colleagues who looked at aerobic exercise in 21 obese NAFLD patients compared to controls. And they found that aerobic exercise at the end of 12 weeks, there was a 21% reduction in the treatment arm compared to the control arm. So aerobic exercise definitely reduces intrahepatic triglycerides. And the Newcastle group in 2011 published the data on resistant exercises in effective resistant exercise in fat. And they showed that there was a modest but clinically significant reduction in intrahepatic triglycerides with resistance exercise alone. They got a 13% reduction compared to controls, and that was modest, but still it was clinically significant. And this is a meta-analysis of all the studies comparing aerobic and resistance exercises that was published by Hashida in 2017. And the meta-analysis showed that both aerobic and resistance exercise is equally effective in reducing intrahepatic fat, and there was no clinically significant difference between aerobic and resistance exercise. This is a good news for your obese gentleman, the obese banker, because he doesn't have the cardiorespiratory reserve to do aerobic exercise. You can start with a resistance exercise. You ask him to take short bouts of resistance exercises and gradually build it up. Whereas your young IT professional, he might be happy to do aerobic or a high intensity interval training if he doesn't have time for a long duration of aerobic exercises. So you've got a wide variety of exercise regimes to choose from. And you have to choose wisely so that your patient adheres to the regime. And coming to the intensity, what's the intensity of exercise and NAFLD, role of intensity of exercise? This is a study by Sang et al. That compared moderate intensity exercise versus vigorous exercise and showed that both moderate intensity and vigorous exercises produce similar reduction in the intrahepatic triglycerides. So the intensity of the exercise doesn't matter. Either both moderate and vigorous exercises can reduce intrahepatic triglycerides to the same level. And again, keating, they divided 48 patients into 4 groups. That is high intensity, low volume group, low intensity, high volume group, and low intensity, low volume group, and a control group. And they showed that even in patients in the low intensity, low volume group had clinically significant reduction in the intrahepatic triglycerides compared to the control arm. That's a patient who did not do exercise. And that's again a good news for your obese banker, because even mild exercise, the low volume, low intensity exercises can help him to clear his fat. He can start with a low volume, low intensity exercise, aerobic exercise, and slowly work his way up. Coming to NASH, as I said, there are no studies looking at inflammation or fibrosis in exercise and inflammation of fibrosis. All the studies looked at a combination of diet and exercise, and those studies that achieved a 7 to 10% weight loss had significant reduction in inflammation and fibrosis. And only study that looked at regression of fibrosis in with exercise is published as an abstract in the 2019 EASL. That's the study by O. Gorman. They showed that 58% of their patients had at least 1 point reduction in fibrosis after a 12-week aerobic exercise. So aerobic exercise might, a 12-week intensive aerobic exercise might help in reducing fibrosis, but that needs further studies. So to summarize, exercise is a polypill for the management of NAFLD. We just need to learn how to get patients to take it regularly and seriously. And let's see how we can implement it. So that when you prescribe an exercise, the exercise prescription should promote adoption and long-term adherence. It should be acceptable to the patient and it should be achievable by the patient. You can start slow and gradually work your way up. In your obese gentleman, you can start by giving breaks to sedentary lifestyle, asking him to get up and move more and take more steps and reach the goal of 10,000 steps per day, and gradually add in a resistance exercise and then add in a low volume, low intensity exercise and gradually work your way up. Whereas in your young gentleman who is properly physically fit, you can ask him to do either an aerobic exercise or a high intensity interval training depending upon his time. And so as already we have seen, we can choose between a wide variety of exercise regimes to be chosen from aerobic or resistance or high intensity interval training. And you can ask a patient to start slow. You can add 75 minutes. You can start with a 75 minutes increase from the baseline, what they normally used to do. You can ask them to increase by 75 minutes a week and then gradually build it up to a 150 to 300 minutes per week of moderate to vigorous exercise divided into 3 to 5 sessions. And always it's better to add a resistance exercise at least 2 sessions per week because it helps to build muscle and endurance and it helps the patient to adhere to the aerobic exercise regime. And how to ensure adaptation and long-term adherence? You have to explain to the patient what NAFLD is, what are the risk factors, the risk of cirrhosis, liver transplant, HCC, and you have to teach them that it's reversible and benefits of exercise. And always address any misconceptions. Teach them about energy balance. Teach them that the calorie you consume should be less than the calorie you burn. So you should achieve an 80 calorie balance to reduce weight. And exercise should be tailored to individual patient physical fitness, comorbidities, and preferences. And always encourage self-monitoring. And always have signposts to local exercise program, weight loss program, workers club, because that helps your patient to be adherent to your exercise regime. And this chart summarizes summarizes various techniques to ensure adherence. So always take your patient into confidence, set smart goals, discuss the action plan with them when, where, and how they are going to do it, and always ask them how confident you are that you will achieve the target. And always identify barriers, and you should have alternate plans to cope with the barriers. And always ensure you always ask the patient to self-monitor the progress. And a success of any lifestyle intervention is by the multidisciplinary approach, and all the stakeholders should play an equal role in the management of your patients. So I come to the last slide. Thank you.
Thank you, Charles, for telling us that exercise is the single polypill which can solve all the problem. While you were speaking, I was just wondering about the case that Dr. Ashish had presented. A shopkeeper who has to sit in his shop from 9 o'clock in the morning to 9 o'clock in the evening. How are you going to convince him to exercise?
So you can start with interruptions in the sedentary behavior. That's the first point to start with. And that is important for us doctors also who sits throughout the day in our clinic. So for the man who sits a shop, ask him to get up every hour. Just keep a reminder, use He can use either a wristband or a pedometer or a activity monitor, and ask him to get up every hour. That can be a good start. Ask him to get up every hour, take a few steps. And in between, you can start by short walks, 3-minute walks every 3 or 4 hours. So he's sitting for 12 hours, short walks every 2 or 3 hours. That would be a good point for him to take instead of asking him to work out for 45 minutes or 1 hour in the gym.
Possibly
always start
asking him, I am a reliable person who can run the shop when he is not there, isn't it? So,
but you can always find time if you want. If you can motivate him, if you can teach him tell him that fat liver is reversible with exercise. If you can motivate him, then there's always means and ways to find time.
Okay, Dr. Kaushal.
Dr. Huda will be highlighting on it further.
Yeah. So thank you, Charles. And I think you emphasize the fact that it is a multidisciplinary approach of making the patient lose weight, especially with fatty liver. So we have Dr. Anjali Huda, who's the leading practitioner of metabolic medicine in New Delhi, who will be talking to us about her tricks of how she's able to make these patients adhere to their lifestyle management. Dr. Huda, please.
Hi, good evening, everyone. Thank you for this opportunity to all the esteemed colleagues and seniors and all the viewers who are watching. I hope you'll be able to take something home today. So I have been practicing obesity medicine for quite a few years now, and a lot of practically I get a lot of such cases, and I'm going to take control of this slide. Okay. So we know the prevalence. I don't need to tell you this. This is something, the data is it's in the public domain. So a lot of prevalence of NAFLD. Everybody has already stressed upon this. So my question is, there's a lot of misconception even amongst the medical community about the proteins intake in patients of NAFLD. And most importantly, if you see this question, it is kind of confusing, but I would love a poll on this to see how much everybody already knows about how much protein to have.
People are yet polling in.
Okay. So I can continue, I guess. I think I should continue because I don't want to take too much time. Well, so this is just a question that arises all the time, and I get a lot of patients who come to me and say that if you give me so much protein, my kidneys are going to fail. That is a biggest challenge that I face. We all know that in medical school and in my internal medicine MD, we were not being taught about we are taught about how much protein, but in actually practicing that medicine outside of your academic setup is different because the patients have questions. And the biggest question comes from the fact that please don't give us so much protein, or this doctor is telling me not to have so much protein. That person is telling me to have not so much protein. So this is a very, very big question. Dr. Ashish had shared this amazing presentation about the protein and the low carb. And I think that was great. And Dr. Eileen had talked about do not restrict fat, but we have to restrict the fat and carb combos. So if the poll is ready, can I move on? Wow, that's great. I'm so glad that everybody is answering this question. It's perfectly answered already. And the problem is that a lot of patients come to us about saying that medical professionals are telling us not to have. So I can go to my next slide. All right, so I have a case presentation, very typical. I practice in an urban setting, so my patients generally belong to the urban area of South Delhi. So this is a patient, a 60-year-old male presenting with bad burps, digestion, pain in stomach, bloating, disturbed sleep, constipation. Now this is a very common scenario. That's why I picked up the case, because this is common. Most of the people you will come back, they'll have constipation, disturbed sleep, bloating. This is what I see almost at least daily. Patient's not been feeling well since a trip from Europe. He's had diabetes, which is uncontrolled. He's changing doctors. And this is also a very typical scenario where patient will go from one doctor to the other. And he's trying to control his diabetes through medication and diet, but he goes off and on the wagon, and he's kind of fond of drinking, owns a restaurant, so makes things very difficult for him to resist the kind of food that is given there. And he keeps on trying new cuisines, and he was started on long-acting insulin before he had come to me. And at the time, the weight was 92.9, and you can see all the thing. And there was a high waist to hip ratio, which is visceral adiposity, and BP was well controlled, but he's had diabetes for a while. And at the time when I saw the patient, the HbA1c was 7, and he had elevated. I will show you the labs going further. He also detected TTG antibody, which is for gluten. Tissue transglutaminase was detected in his blood work, and he had brought all this blood work to me. And here are the medicines you can see on the screen. He's on some of the medications prescribed by an esteemed gastroenterologist, and he was diagnosed to have SIBO and NAFLD already when he was here. Okay, I can go to the next slide. All right, this is a fibroscan. I've hidden all the identities so you can see this was done. And next slide, please. And this is a very, I'm sorry for the picture quality. This is what the patient had presented to us with. And you can see I will show you the labs further, but this is how you can see the LFTs are elevated. Okay. And I'm going to go to the next one. So this was a prescription given by the gastroenterologist, which the patient had shared with me. And I put a screenshot of that. Okay. All right, so this is the breath test for SIBO that was done, and patient is clearly having SIBO, which is bacterial overgrowth of small intestine. Okay. I'm not able to move to the next slide. All right, so this is the lipid profile, which was brought. So you can see the elevated triglycerides, the low HDL. You can see the LDL is high, and patient is obviously diabetic, so we need to bring that down. So next slide. All right, this is an image I took, and the reason why I was pointing out at the animal protein is because a lot of people are doing keto, like Dr. Eileen said, and too much animal protein is being consumed, and it is really not good for us. And a lot of patients also need to be on omega-3, MUFAs, as has already been explained to you by other doctors. And a patient here is diabetic, and this is a slide on insulin resistance. But here we have clear diabetes and clear dysbiosis of the gut because patient has SIBO. And so patient needs to be managed accordingly. And SIBO is a very common scenario. So this is what we did. So we did a hypocaloric diet. Now, first important thing is to always take patient's recall of the diet that he's having. So very important to know what they are eating. Like Dr. Ashish had explained how the patient is eating. So we go by that very skeleton. We don't go by something we think is right. So we go by the choices the patient will make. A lot of places I see a handout is given for a diet. That is not the way to do it. I have learned to actually tailor make it for the patients, because they are the ones who have to adhere to the diet. So it's something that you can give a lecture to them, but being a part of their lifestyle is very important. You have to understand. So we've given lean proteins, reduced animal protein. This patient was eating chicken every day, mutton almost 3 times a week. The glycemic index was explained already. So low GI vegetables, low GI fruits were given. Fruit is very overrated. Some in this NAFLD population, people are having big plates of fruits, which is really not recommended. And this patient was put on gluten-free grains because he detected TTG antibody, and then we reduced the fructose and lactose. We only allowed the dairy products which were cultured, so like lassi and chaach and all that. Fiber was given in form of psyllium husk and also a lot of vegetables. So he was asked to reverse the ratio of macros in the meal from 2 roti and a sabzi to 1 roti and 2 sabzi. Something, just reversing the ratio is good enough for the patients because they must eat 1 roti in their lunch. That is very common. People will not go on low carb like that. They will just push for roti and some kind of snacking that we have to provide replacements for. So if the patient is having certain kind of a cookie, you please replace it with a healthier one, and for that you have to know the market. You should have been a shopper yourself, and lot of the patients will find it difficult to find, so you have to also give pictures. So what I do is I give pictures. I mean, I have a team, they provide the pictures and the location where the product is sold, and the patient can easily go. So one day we give the patient to do all the shopping. So shopping list is provided majority of cases, but some people are okay with not being given a shopping list. So very important. And also consider the nature of job. So just like Dr. Panikal has mentioned, there's a person and, who's sitting at a shop. Now, if that person can't work out, we have to understand that we can make the compensatory workout at least on the Sunday or a Saturday, wherever he's taking an off. So also we have to address the cheat meals. Patients will cheat. Patients will not refrain from cheating. So what you're giving in the diet, you have to make a buffer for it. So let's say you may prepare a diet like a DASH diet or a Mediterranean diet for the patient, and you made a buffer. You must make a buffer, because if you're giving 1500 calories to a patient, make sure that you should know that the patient is going to go over 2000 for sure, because there will be social gatherings, there will be alcohol, there will be festivals, some celebration, and food is a part of in our culture for celebration. So we have to make the patient understand. So then very close follow-ups are important. So I think if my friends, my physician friends who are struggling with not having adherence to the diet of the patient, what you must do is you must please dedicate some kind of coach to the patient, or some kind of a follow-up system, because patient falls off the graph very soon. They become demotivated. The day they come to the clinic and the day they walk out, and the day they come back after 2 weeks, 3 weeks, some people don't make any changes in their life. So you have to keep sending reminders. Maybe you can use a text service or a WhatsApp service, something that will keep the patient engaged at all times. Like for now, like everybody's listed with this, if I don't engage you, you're going to get bored and you will not have any space in your head to listen to what I'm saying. So it's very important to engage the patient in constant activities and motivational messages, recipes, some kind of, next slide, please. This is a sample diet plan that has been given to this patient. Now you would wonder that this is very, it looks very Western, but the patient is an urban Indian, is in this setting. So this may look like a little Western, but patient also is getting roti. Patient is on gluten-free roti. Patient is, I have decreased the carbohydrates. So as Dr. Eileen mentioned, do not take the carbohydrate out. We have to decrease it and put the complex carbohydrate in place of the simple carbohydrate. So to understand complex carbohydrate, everything that has fiber is a complex carbohydrate, like a vegetable or a oats or a quinoa or a brown rice or a wild rice or a red rice or whole wheat grains. They are all complex carbs. So you need to give patient complex carbs, not simple carbs. So let them decide what complex carb they will like. Some people will not like oats. Some people will not like quinoa. Some people are not even familiar with the quinoa. So you have to understand we can use lentils, but too much lentil also will not help the NAFLD patient. So we have to understand, do not too much fruit, not too much lentil, just a balance of food is very important. And having a good nutritionist on board is really, really helpful, because they can help you form the plan. So this is something, you guys can take a hint from. Next slide, please. All right, so supplemental advice. I just wanted to add this because a lot of the patients are, they have dysbiosis of gut. So I use probiotics, and I use pro and prebiotic food separately, which is charged kombucha or some kind of fermented dishes. Then magnesium citrate is very good for people with constipation. This population is constipated because they're not already having too much fiber. So psyllium husk is safest fiber that I use. Because patients who don't eat vegetables, you will be surprised to know that Indian patient thinks aloo and paneer is vegetable. So we have to do the psyllium husk supplementation for a few days, so that there's a bridging of gaps, so the patient understands that we have to eat fiber and can't be on an oral supplement throughout their life. So slowly, as they go up on their fiber, you can give support with psyllium husk and then take it down. Curcumin for inflammation, obesity. The patient is obese, and curcumin is an anti-inflammatory. Omega-3 fish oil, great for his HDL, and also again an anti-inflammatory. Next slide, please. At the end of 3 months, patient feels much better. So I'm kind of showing off that we had this result. Patient is off insulin. He's, the HbA1c now at the last week was 5.8. We don't have his recent fibroscan, but LFTs were done. I'll show you the trend. Next slide. This is the weight, how the patient has lost from November to Feb. He's lost almost 9 kgs. Next slide. And this is a trend of lipid and liver profile. And I want you to see that how the patient profile has changed, how the LFTs have changed. And also you will see the triglycerides are back up again in the month of July. So now if the triglycerides are back up again, the patient has obviously started to non-adhere, because patient is now not in follow-up. So if there was a 3-month follow-up done, patient is now due to come back. So reminders have been sent for him to come back, and the patient, this follow-up is very important. You need to keep sending reminders, especially when you know that patient has a tendency to fall off the graph constantly. So next slide, please. This is his sonogram of the abdomen. You can see that the fatty liver has gone to grade 1. Next slide, please. So what were my challenges in management, which I think all the physicians face, is non-adherence to the diet, for which I have told you, you must have a great follow-up. You must have reminders, motivational messages, some kind of engagement with the patient. Alcohol consumption is very common in a lot of, especially in urban Delhi. So alcohol consumption, you have to tell the patient to, basically have a little ration for it, not have too much of alcohol. They will not stop, but you can always give them the option of not mixing sugary drinks with their alcohol and stuff like that. Social life distractions, biggest problem, because there are a lot of festivals in our country, and you have to let them be. You have to make sure that then the patient has cheated, patient has done all this. When you bring them back, you please tell them how to do a little bit of a compensation, which is like a cheat meal, cheat sheet you can give them. I can provide all this to you if someone wants to message me separately. So you need to provide the patient a little bit of a compensatory method if they have cheated and if they have gone off the wagon, because they will need that. They need to start managing. So you need to also educate the patient. Education is very important. Constant demotivation is there because obviously diabetic male and obviously stressed and diabetic patients are depressed. It has been seen. So a constant demotivation keeps happening. Next slide. These are the references for everyone, and you can take a screenshot, and I think I'm done.
Yeah, thank you, Dr. Anjali. I think your second last slide was the most important one, where you were talking about all the tricks. So I did not disturb you. Otherwise, I was hoping to interrupt you in between.
You should have.
To wind up. So let's move on. Dr. Chawla, can you take over from here? Dr. Chawla, are you there?
I'm there, Kaushal. Just wanted to know from Dr. Anjali, how many patients of hers adhere to her diet and how many are failures, maybe at the time of discussion. But it would be a pleasure for me to introduce Professor Arun Sanyal, whom I've known for almost 35 years or even more. We were together at All India Institute. He moved to US, and now he is the man of non-alcoholic fatty liver disease, well known throughout the world. He's working at the Virginia Commonwealth University, and He has done a lot of work on non-alcoholic fatty liver disease. He's going to talk to us on a very different aspect today. We always knew of sleep apnea syndrome in association with non-alcoholic fatty liver disease. But he's going to talk to us today on circadian clocks to NAFLD, role of sleep in NAFLD. Arun, please.
Okay. Thank you, Yogesh. Can you all hear me?
Yes.
Yes,
okay,
sir.
good. So you've already given away my question. So we'll go through this very quickly. So if anybody gets the answer wrong, that's really bad, since Dr. Chawla has already given the answer. So anyways, here is the profile. 45-year-old lady who works as a nurse in a busy hospital, presents with fatigue and intermittent heaviness in the right upper quadrant. She stopped having periods about a year ago, and since then also has been feeling more tired and fatigued. She saw her primary care physician, who noted that her liver enzymes were mildly elevated, but reassured her that it's not very important. These changes are routinely seen, don't mean anything. But somehow she was not reassured. She works as a nurse, and she talked to some other doctors who said, why don't you go see a gastroenterologist? So she has a history of gallstones requiring cholecystectomy 3 years ago. She was told to be pre-diabetic in the past. She has 2 children. Last child was 15 years ago, and she did have toxemia during her pregnancy, requiring C-section. On examination, blood pressure is as you see it. Weight is 75 kilos, normal heart and lung exam, and then anterior liver span's about 7 centimeters. You have the labs over here. I'll give you a minute for all of you to look at it. And you can see the liver enzymes are marginally elevated. Nothing dramatic in any of these labs per se. So which of the following elements are particularly relevant in this history that have not been specifically addressed in what I have shown you? And that was sort of originally missed by whoever took the history. Symptoms of depression, history of retained stones, pancreatitis. Symptoms of depression, weight change, change in bowel habits. These are all things that were not in the history that should have been asked. Symptoms of depression, weight change, abuse of prescription narcotics. And then symptoms of weight change, depression, and sleep pattern.
I guess people are still polling, sir.
Yeah, well, let's keep moving. What happened? Did I lose my screen?
So you can share again.
Case study. Okay. So the correct answer, of course, is the last one, because as Yogesh said, we're talking about sleep. So let me just put this in little perspective for you. So originally, when this earth that we all call home was created, as you know, we are exposed to the sun half the day, and half the day we have no sun, and that's called the night. So our 24-hour cycle is divided into a period where we have exposure to sunlight and period where we do not have sunlight. Why is this important? This is important because when life evolved, this solar energy was incredibly important for the initiation of life on this planet. And if you remember, your original bacteria and algae that developed primarily relied on photosynthesis to generate energy. So photosynthesis by definition requires sunlight, right? Now, evolution required, because these machines were, these original primordial cells were not very efficient. So in order to maintain efficiency, you did not want your metabolic machinery turned on all day long, your transcriptional machinery for all these photosynthetic enzymes turned on all day long, when the sun was only available for half the day. So there evolved mechanisms to regulate your metabolic machinery so that it would only turn on when the light was on. And so this led to what are known as clock genes. And these clock genes are preserved all the way from the most primordial bacteria all the way to human beings. So energy homeostasis, of course, is essential for life, because no energy, no life, right? So you have to make ATP, and that's why we're talking about nutrition. Nutrition is how we get our energy. So as we have evolved as a species, and through all the animal species, a central regulator of many biological processes that require energy essentially are regulated by these clock genes. And these clock genes have various inputs, which involve light, which is processed through the pineal body, goes to the supracortical nucleus. It goes through other signals that are related to food intake that is linked to when we are awake. And so there are external inputs and there are internal molecular circuits that feed back onto these clock genes. These clock genes output, of course, are like master regulators of many metabolic pathways. And through modification of these metabolic pathways, they can modify inflammation, fibrosis, oncogenesis. So the clock genes are central regulators of normal physiology. And if you look at the circadian regulation, there is not only a central clock, which is in the hypothalamic circuit and linked to the supracortical nucleus, but there is also a clock in every organ, starting from your intestine to your liver to every organ in the body, because the clock then regulates when things turn on and when things turn off. And we have historically considered all of the biology of these different organs in a very monomorphic way, that when things come on, they stay on, and we say, okay, if you give high fat, then this happens or that happens. But the point is, in an individual person, these things change from day and night and all of these. As you can see over here, there are transcriptional activators that get occupied during the day, and then there are others that get occupied at night. And these, of course, can be epigenetically modified as well. So the master clock, which is determined by, and its functionality, which is determined by rest and activity cycles, the availability of food and how long you're fasting. And this relates to your conversation about the intermittent fasting and the 15-hour fasting, and also to temperature cycles. Our body temperature, fluctuates through the course of the day. These then feed from the central to the liver clock, which then modulates all of the different functions that are shown over here, which of course, many of these, you can clearly link the dots to the development of steatosis, inflammation, and fibrosis. Now, there are several different types of clinical disorders that can impact how the clock genes work. First of all, sleep deprivation. We know now, thanks to our very connected world with constant 24/7 television, 24/7 Twitter, messaging, that people are in general, compared to 30 years ago, at least there's literature in the West, people in general are sleeping 1 to 1.5 hours less per day than they were 25 years ago. And this is, of course, linked to our social behavior with all of the social media services. So when you get sleep deprived, as you can see over here, it alters through modification of these clock genes a number of hormones that are critically involved in your food intake behavior, such as leptin, ghrelin, etc. Net result being you essentially increase your appetite and you eat more, and it resets your central barostat, because the body has a way to modulate and regulate your barostat, which over time, by the way, keeps going up, which is why with every passing decade, you put on a few more pounds than when you were 25 years old, and it's harder to get off. Why is it harder to get off? Because it also regulates thermoregulation and your energy expenditure. And of course, sleep is critically linked to the hypothalamic axis and your cortisol and sympathetic activity. And both, as you know, probably most familiar with, are directly linked to insulin resistance and glucose tolerance. So there are multiple mechanisms by which, if a person is not sleeping, so particularly for shift workers and particularly for women who work the whole night, come back, they have to still expected to get their children off to school. They have to get their husband or spouse off to school, maybe even make food and make sure there's food for the in-laws, then get a little bit of sleep, then get up and make sure there is laundry and marketing, whatever needs to be done, get everybody ready for the evening meal before they have to head back to work to do the night shift. So particularly for those people, it's very challenging. And one of the common things, as a general rule in managing lifestyle, whether it's obesity in the context of obesity or NASH or whatever it is you have to really understand the individual patient and their life, because it is only in the context of their life that you can start making small changes that actually can be implemented, not only in the short term, but also in the long term, because nobody is going to change their life 180 degrees because it will have an impact on their family, it will have an impact on all other things, and with all the other constraints in society and social responsibility, etc., many people are unable to engage. So asking about sleep so we've historically always felt insulin resistance is food, exercise, but it's really a three-legged stool. And the third leg is sleep. So the other possible way sleep can affect our patient is sleep apnea. And because we know when you get sleep apneic, you get intermittent hypoxia and your sleep gets fragmented. There's a huge body of literature connecting sleep apnea to oxidative stress, inflammation, and sympathetic activation. And I know that it's not just in the West, even in India, snoring and sleep apnea is extremely common. If you've ever taken the Rajdhani Express from Delhi to Bombay or Calcutta, you will know that half the compartment is snoring. So there's an exceptional amount of sleep apnea that is present in these patients and often not really interrogated. And so, of course, sleep apnea, due to all of these mechanisms, directly again affects metabolism, glucose metabolism, fat metabolism, de novo lipogenesis, and oxidative stress and inflammation, which then can contribute to worsening. And in fact, there's at least some studies suggesting that people who have significant sleep apnea have more severe disease. Remember that NASH is primarily a centrilobular zone 3 disease. So when it is that is the zone. The liver is a hypoxic organ. The liver gets 70% of its blood from the portal vein, 30% from the hepatic artery. So compared to other organs, it is getting blood that has already been deoxygenated in the intestine before it gets to the liver. So starting with a relatively low oxygen state, the centrilobular, by the time the blood goes through the sinusoid and gets to the central vein, that region is particularly susceptible to hypoxia. So sleep apnea can accelerate and worsen the injury that is produced by the metabolic stress in that region. And there's some data that, as I'm showing you over here, that when you put people on CPAP, you actually start seeing improvement in some of the parameters of liver injury in this population. So there's some clinical pearls that sleep impacts metabolic health in 3 ways. decreased total amount of sleep, and disruption of the day-night cycle, disrupted sleep patterns. So even if you sleep, if you're not getting enough REM sleep because you consumed alcohol, you taking some drugs, you are stressed out, whatever else is impacting your sleep pattern and your REM cycles, it is extremely important because the REM cycles are linked to how your clock genes work. And in fact, one of the first things that gets disrupted metabolically when you start becoming obese, and it doesn't matter whether you take a high sugar or high fat, it doesn't matter why you become in diet-induced obesity, the clock genes are the very first set of genes that become abnormal. And lastly, of course, sleep apnea. Now this, of course, is very useful because you can actually intervene for all of these. And this will increase, none of these is a single tool that will fix every problem, but this increases the efficacy of your other lifestyle interventions that you put in. So a NASH evaluation is incomplete. This is a take-home message. A NASH evaluation is incomplete without the following questions. When do you go to bed? How many hours of sleep do you get? Do you feel rested when you wake up? So that should be a clue, because if you wake up tired, that is a very good history-taking question that you're having disordered sleep. And do you snore? Or do your family members complain about your snoring? Or if the spouse is there, ask the spouse if the person snores. And last but not the least, I have to put it out there because I didn't hear it from anybody else, is when you're doing lifestyle intervention, you have to talk to the family. You have to engage the whole family. Telling one person in the family to change and start eating a very different kind of diet where the rest of the family is eating parathas and desi ghee, and that's what they like to eat. You got to understand that's comfort food for them. So it is not going to work unless the whole family understands and engages. And if the likelihood of having fatty liver disease in family members who are following the same lifestyle is extremely high, much higher than the general society. So it is very important when you get a patient to also ask about what's going on with the family, and whenever possible, try to engage in lifestyle intervention as something the whole family engages in a more healthy way of living rather than treatment of a disease per se. So I'm going to stop there.
Thank you, Arun, for giving us a totally different perspective about non-alcoholic fatty liver disease. We have Gaur, it's 6 o'clock, and till what time do you want us to continue? We have about 15 questions coming from the audience.
Hello, my suggestion is that we take the questions first, we have the discussion, and thereafter, if there is time, then I'll have about 3 to 4 slides to show, but that can pass on. I think today's discussion would be most important.
Fine, fine.
And so, also, I would like to remind the audience that we have done a kind of a half-hearted job on very important topics like diet and exercise, because there's a lot to be covered. We have just about scratched the surface. And for instance, we haven't talked about intermittent fasting at all, which is a very important new concept. And there would be different issues of exercise which are coming up as to what to do by way of exercise during lockdown and so on and so forth. But that would be probably another area for more detailed discussion. But at the moment, I think that we can take the questions that people are waiting for.
Yeah. AC, you have the questions with you? Otherwise, I'll start with a couple of them.
The first question is from Dr. Sanjeev Khanna. He has asked that many diabetics like to eat 4 to 5 fruits daily as a part of their healthy diet. Is this okay?
Can I answer that?
Yes.
Okay, this is like I talked about in my talk also. Eating too much fruit has become they think it's healthy, and you have to understand the fruits contain fructose. So if you're not concentrating on the low glycemic index, which is very difficult for us to explain to the patient all the time, so we should just minimize the fruits to maybe a cup of fruit or 2 cups of fruit a day, because cup is like literally a cup. We are not a plate of fruit. So we have to tell them about the portion sizes, which is very important. A cup of fruit, I always tell them, get the cup of fruit in a plane that is the amount of fruit you eat at one time. So most of the patients will understand, okay, what is a cup of fruit? Otherwise, there's too much fructose.
I might also add, that there are types of fruits which have a lot of fructose and they're very juicy. For example, pineapples, mangoes, and lychees. On the other, or for that matter, even your melons. On the other hand, you have some which are much richer in fiber. For example, pears and apples. So I usually tend to also specify or give them a choice as to which would be the fruits that they could choose from. Any comments on that? Like I love mangoes, and I can tell you from my practice in Lucknow that during the summer season, most of my patients put on 3 to 4 kilos just binging on mangoes. Anjali, what's your reaction to that? Do you get mangoes in Haryana?
Yes, sir. We do get a lot of mangoes in North NCR region. The thing is that patients will eat mango. We cannot stop them. So we have to tell them to portion it. So I will tell the patient to have a slice of mango, or maybe have one full mango and then compensate on the fact that they should not be eating rice or chapati in that meal.
Eileen, what do you do when your Alfonsos are out? You're muted, Eileen.
Unmute yourself, please.
Portion control is the way to go, because we cannot completely stop them from eating, a lot of things. So we need to tell them how to portion and when to have it, the right time to have it.
Yeah, I think the question stems from the fact that, when the WHO revised their food pyramid guidelines, in the last one, they included 5 portions of fruits. And they did, that's the food pyramid. I'm sure all of you have seen that.
Yeah.
The problem is that they did not specify what types of fruits. And most of the tropical fruits, usually, many of them, they're actually loaded with a lot of fructose. And that's the reason why, obviously, you can't ban them. But the fact of the matter is that, yes, I think proportioning them is probably very important if they can. But if they like to binge on fruits, then, there are others which are good.
I would add here that fruit juices are worse. So
terrible.
Totally.
Terrible. And I think, Anjali, for your practice also, let me tell you, there's a beautiful paper. People who like alcohol as cocktails. So if they have it with fruit juice, the fructose with alcohol actually doubles or more than doubles the injury to the liver. So actually, it's better to have a scotch neat rather than to actually have a fruit juice cocktail.
Yeah, can I say something?
Yes, please.
Questions related to this. One is both to Anjali and Eileen. When you arrange for a dietary counseling, do you get the cook and the mother-in-law also in for?
Yes. Yes, I actually, sorry, Dr. Eileen, you can answer first.
No, definitely. It is a family counseling, because it's not a single person that will be exactly responsible. And there's it's not one session of counseling that everything happens in it. So what we do is we go one by one. So sometimes we just take one thing at a time. Maybe sometimes we just take the portion control. Sometimes we take just the type of food, and sometimes we take only one particular meal. So it all depends upon what is culturally possible for the patient to do.
Okay, and then Dr. Sanyal talked about comfort food. If you're taking comforts away from the patient, it causes discomfort and depression. And how do you deal with that?
Yeah, so
chocolates.
Yeah,
dark chocolate.
Dark chocolate.
Yes. So actually, comfort food is a very relative, subjective term. For somebody, dal chawal is also comfort food. So, and dark chocolate may not be their comfort food. So everybody's comfort food is different. And there are people who bargain with you, like, they say, like, I love pani puri, at least give me to have it once in a week. So for them, that is their comfort food. So we got to, gauge and understand what they actually need and what makes them, really feel better. Sometimes when they diet for a long period of time, they have this something called a diet fatigue. Like they literally are fed up and irritated with it, and they just want to leave it. And so that's when we give them a kind of a break, where we tell them that this is how you can substitute one for the other. So comfort food is included in their diet, and we tell them how to adjust with the comfort food.
Maybe the quantity
needs. Can I add something?
Please.
Yeah, so I just want to add a couple of things that is really important for long-term success, to approach this as living healthy rather than prescription for a disease. Because right up front, if you give the patient a sense or perception, because perception is reality for them. So if you give them the perception that this is something I am taking for a disease, I need to just take it for a certain period of time and then I'm off the hook and I'm back to doing whatever I always like to do. But the people you will find the biggest success are the ones who say, you know what, I can have a fantastic life and really enjoy living in a different way. I'm adopting this to feel better about myself, be healthy, and it's more holistic and sounds a little, almost voodooistic, but it's actually true that and I'm hoping that Dr. Kande and Huda will agree with me that their biggest successes are when the person thinks, this is fantastic, I'm living my life in a whole different, they adopt it as something they're invested in as a positive, it's a positive construct and not absence of a negative thing. Would you agree?
Yeah, totally agree, totally agree.
One more thing is there, whenever we have lectures or webinars in which case series are presented or a case is discussed, you find 6 months later, all the tests have become normal and the patients have improved. But most of us who are in practice for a long period of time, we know that all these patients will come back with the same problem again. These improvements that we are shown in webinars are not really lasting improvements. The patients switch back to their old habits very quickly. And how do you deal with that?
May I add to that, Anil? Also, there is a particular bias in presenting cases. We usually always present our success stories because, nobody would be foolish enough to actually present a failure story. But actually, I was thinking of doing a seminar once on only discussing failure.
So Gaur, can I add to this? So I think it's really important initially, and this is something that we as hepatologists are not really trained to do. So at least at our place, part of the team is a psychologist. We have actually a behavioral person. We started including them about 15 years ago. And it's incredibly helpful because they find out things. For example, if somebody is growing up in a family and they are getting yelled at by whatever, or their father beats them or something, they learn to eat as a way to cope with their inner anxiety or stress, or they're getting bullied in school. And it happens in India. I can tell you firsthand that if you're a skinny Bengali boy growing up in Delhi, you get beat up on a regular basis on the playgrounds. Even the girls would beat me up and steal my lunch. So you then develop habits to cope with all of this that only now at the age of 60, I can look back and say, yes, this is how it happened. But people don't even realize that these are coping mechanisms. And the way this is all surfaced is now there's huge amount of data that after bariatric surgery, the suicide rates are up. That's because, if you don't understand the background of why people eat the way they do, and you just clip their stomach, you create a whole new set of problems. So I think really taking that time to understand the barriers and why they adopt the lifestyle they do is critically important. There's a lot of problem with addiction behavior.
Yeah.
So food addiction is just like alcohol addiction. The neurocircuitry is completely worked out. I can give a talk at another time on that, but it's the same set of triggers. And once the addiction circuitry is turned on, it's turned on. We know when you stop smoking, you gain weight. Why is that? Because the addiction circuitry demands to be fed. So if you stop one thing, it wants something else to keep that circuit going because it's a hedonistic thing that people want. So I think those are really critically important things for long-term success. Yet as a medical community, we have done very little. We give it 1 second. We say lifestyle, very important, but nobody follows it. Let's find a pill. So I think that's where the field needs to go. If we're really going to solve diabetes, cardiovascular disease, cancer, and NASH all at the same time, that's the direction we have to fix.
Can we take a poll from all the people who are yet logged in? I believe it's about 1100. How many of them want a more detailed discussion in a separate webinar on this issue of eating behavior, fooding, and lifestyle? Because, today we have only scratched the surface. So I think Arun made some very important points. So those of you who are interested can just put in a thumbs up or a show of hand or whatever. And depending on that, we'll decide on our future webinar. Sorry for that.
Can I quickly add something? What I do, since I learned that in the US, I do a PHQ-9 for every patient. And it's really a quick way to see their depression screening, so that you can have that patient, set out to be referred to a psychiatrist or a psychologist, depending on their PHQ-9. It's kind of been very helpful for me if somebody else would like to do that.
The behavioral sciences is still relatively underdeveloped in India, considering the size of the country and the stresses that people are under on a day-to-day basis just to survive. Compared to other specialties in the medical field, I think the behavioral sciences in India, and there's still a lot of social stigma to seeing a behavioral person that needs to be tackled. It's a complex issue.
No, another issue, I'm happy that you brought it up, Arun, is economics. You see, if it's a very well-to-do person in South Delhi, he wouldn't mind spending a lot of time with Madam Huda, because, it's a very fanciful thing. Obviously, you talk about whether to have avocados or to have grapes. In the kind of practice which I have in Lucknow, for instance, the poor people, a referral to a dietitian means another 900 rupees gone. And another visit to a psychiatrist or a counselor means another 900 rupees gone. And, he says that, look, I came to you for a digestive problem. So whether you like it or not, if you are practicing in the kind of India that we are familiar with, which we call Bharat, the physician has to be able to deliver on multiple fronts. It just can't be that, you subspecialize with each person doing a role. It's very good for learning and it's very good for evolution of the science. But ultimately, the delivery route is a single window policy in many a times.
Can I add?
I hope my Indian friends would agree. Yeah, Anil.
Totally.
So there are certain things which a patient cannot change. For example, the shift work.
Sure.
To be doing shift work, he'll have to lose his job to change the shift work.
Exactly.
Similarly, the patient which Dr. Ashish Kumar presented, if he is working 9 to 9 in a shop, sitting in a shop, and he has no help available to run the shop, he's the only person sitting in the shop, he'll have to close the shop to go for a walk. He loses revenue from there. So that is not an option he will consider with any degree of logic.
Yeah,
but the example that I give these people are that if you look at all the American presidents, including the present one, Trump, who spends an awful amount of time playing golf, but he could be criticized. But even his predecessors like Barack Obama or Bill Clinton, they spent 2 hours or so jogging or looking after their bodies, And I keep telling them, if the American president can spare that amount of time because it's his priority, then I think if you think it's your priority, you'll find time, maybe at least 40 minutes.
No, American
sometimes that helps to reset priority.
President can take decisions while on treadmill, but the shopkeeper cannot do that.
The other option is, of course, to innovate. That every hour they can do some stretching while they're still sitting in their shop, or in between customers. You can do chair sit-ups where you grab the handle of your chair like this, like I'm doing. There are a lot of little things that you can do. But very important, if the person has to find it enjoyable. So start with something that the person actually enjoys doing, takes pride in doing, then he'll show off to his kids, he'll show off to his coworkers, he'll get them doing it with him. Then you're more likely to see sustained benefit. But if something is perceived as punishment somehow, then, you know, the first time they can dodge it, they'll find a reason to dodge it.
Dr. Prasanna has raised the issue about red meat. He says the red meat with animal fat generates more trans fats. What are your comments on this?
You know, I think you have to have balance in life. So what I find is something that resonates both in Western patients, plus I have a big Indian community here in where I live, and I see a lot of people, is to ask them to follow the middle path. You know, somehow it resonates when I say follow the middle path. It's sort of, you know, somehow culturally and other ways, it resonates with people. If I tell them, you know, high fat, low fat, this, they start looking at me like I've come from Mars, that they don't know. Because for the average person, trying to translate all this high fat, low fat, keto, Mediterranean, they're like, I have no clue, doctor, well, you're speaking in a completely language that I cannot translate this into anything I can actually do in my life. So I tell them, listen, we have common sense. You know, this is something we have lost in the modern world. You know, watch how much you eat, avoid second helpings, don't overload the plate on the first helping, avoid late night snacking, and particularly identify the refined foods, high in refined sugars, low in fibers. Those are really probably not good for you. You know, try and get enough sleep. Follow the middle path. Middle path is a great way to live your life. And so I think there's simple tools. And one thing is no one single tool works for everybody. You have to really get to know your patient.
Yeah.
Dr. Sheikh Nazir has two questions. One is that does omega-3 have any role in NAFLD? And second is, does yoga have a role in NAFLD?
So I think address the first one with the omega-3s. You know, unfortunately, all of the long-term omega-3 clinical trials sort of failed, particularly where there was histology involved. So it again shows you can't solve, NASH is a complex disease, and you can't solve a complex disease, you know, with a simple dietary manipulation that, oh, if I just ate a few more walnuts or drowned myself in olive oil, I would be fixed for life. You know, if you take 5,000 calories in olive oil when you're burning only 1,500 calories per day, you still have a problem, metabolic problem. So you have to put it in context. Yoga, I will defer, you know, to Gaur and others who may have some insights into this, because I have no data-driven answers to that question.
If I might come in, I was looking at what are the things which we have left completely uncovered this time. So one of the issues was, of course, diet, where we talked about, you know, intermittent fasting, different types, and of the exercise varieties, one was yoga. And I was mentioning to Arun and others that I had last reviewed that topic a few years back, and there were about 40 articles on yoga. Interestingly, most of the articles had shown that there was benefit, about 80% of them. The problem is that with scientists, you go into hair splitting. And therefore you say that although all of them did show benefit, not all, 90% showed benefit, they use different approaches. So some use this yoga, some use that yoga, some use that yoga. But the fact of the matter is that, you know, we often are good at hair splitting, dissecting, because that's what we learned from our first year, dissection in anatomy. But we are not very good at synthesizing. So that's a topic that requires a full review. I think we have been working on it. Kaushal, I thought you were supposed to do that, but because of lack of time, this time we haven't done it. But I think that's a very important topic, which Kaushal, I, and Arun are planning to actually review extensively.
Gaur, I'll just add that Arun Sanyal almost 10 to 15 years ago wanted to do a project on yoga and NAFLD. Arun, am I right?
Absolutely, absolutely.
Yeah.
We never could get enough interest in funding. But we could never get enough funding to support a proper study with appropriate metabolic measures, you know, and other things, and were unable to get it off the ground. Maybe one day we'll still be able to come back to it. into it.
Okay.
What is your opinion about healthy snacks? Is it an oxymoron, or there are something known as healthy snacks?
You're addressing it to Eileen, are you?
Eileen,
Yeah.
and
Okay.
I believe both of them are doing
Okay. Yeah. So, you know, there are a lot of patients when they come to me and they, I explain to them the diet. The last question that they want to ask me is, what do I do if I am hungry in between? So I asked them back, I said, where is the time to be hungry in between? Because you've had your breakfast, probably you've had something in the mid-morning, then you've had your lunch, then you've had a mid-afternoon snack, then you've had a mid-evening some snack, and then they want to have a Netflix snack as well. So more than actually physiological hunger, it is the hunger that, you know, you have in your mind that you are hungry. So what is explained to them is to understand the actual difference between a physiological hunger and, you know, actually feeling hungry just with your thinking. And if they have to eat snacks, what I advise them is, you know, drink your snacks. That would be better in terms of non-sugary drinks. So you can have chas and you can have the other things. So there are a lot of things that can be had as snacks, but
when you said drink and the other things, so I mean, that has left a lot of doubts in our mind.
So when we talk about, yeah, so I'll tell you one thing. So there are a few things which are considered snacks, right? In the Indian perspective, it is the thepla, fafda, chiudas, and, you know, all those things which are considered snacks. But from the diet point of view, we talk about chas, we talk about lime water, we talk about fruit, the fruit that you eat, we talk about your nuts, we talk about the other, you know, curds and yogurt, which is given as snacks. So those have to be explained to the patient that these are the things that you got to think in terms of snacks and not the fat and oil combinations, which most of our Indian snacks, if you just, in every culture, you just try to think what is the snacks that they usually eat, and it is a combination of only these two macros. One is carb and the other one is fat. So most of our snacks, which is a carb fat combination, those snacks are the most dangerous snacks which have to be avoided. So this is what we need to explain in detail to the patients.
I remember once Dr. Gaur Chaudhary and I were discussing, and we talked about this, that patient spends only about 10-15 minutes with you, but he spends the rest of the 24 hours with his family, with his friends, with his mother-in-law and wife and neighbors. So what you say, to have that impact once in, say, 3 months or once in 2 months, is, do you think it is a logical thing that it will have that impact that you want?
It does. It does. So when we actually ask them to maintain a food diary and write down everything that we eat, when we look back, we are able to actually find out what are the things that are actually unnecessary that have been eaten throughout the day. So besides a main meal, they may be eating a wholesome meal, but the foods that they eaten in between are the actual culprits of their disease condition.
Actually, patients who are able to keep diary of their food, I'm sure they will improve definitely.
See, nowadays, there are lots of apps also which patients are using, because they are getting conscious as to what they're eating. They are counting their calories, and they are actually finding out what are the protein foods that they can eat rather than the carb foods that they can eat. So these things are, it is happening, but it is a conscious effort that is on both the sides. It's the dietitian as well as the patient side, because both need to work in, and as Dr. Anjali rightly said, engagement with the patient is the most important aspect here. So if the patient comes to me just on the first visit and he has had the diet like the way Dr. Kumar had this thing, it is very difficult to actually change their diet overnight. So it takes a long period of time by the time you handhold and counsel these kind of patients.
Dr. Ashwini Chopra has asked few questions, and one question is about ghee in NAFLD patients. Is it all right to have ghee?
So ghee, when we talk about ghee, ghee is a part of the saturated fat group. so the total amount of fat that is consumed in the diet is very important, and we say it should be less than 30% of the total calorie consumption. 10% out of which can be given from saturated fats. So in saturated fats, you got to choose whether 10% of that, whether you want to have a cheese, you want to have butter, or you want to have ghee. You can't have all the three. So some people, for them, having the ghee tadka in the dal is the only way to eat dal. So that's when we tell them how to actually choose the right fat based on what they like and what is right for them.
Then there is a question about somebody has recommended that soya is a good source of protein for the patients. And the question is, soya is controversial because of its hormonal effects and some connections to breast cancer. It is often prescribed by the dietitian. What is the panel's opinion?
I think soya is, it can only be safe if it's not processed, because the isoflavones are beneficial to the body, but the kind of soya we get in India is in form of soya chap. I don't know if you've heard of it. And the kind of soya nuggets that we get, they're a little more processed than the actual soya, like soya ki phali ya tofu jo banta hai. But if you ask me, soya is should be given in only moderation, especially to the pure vegetarian patients who are, they lack protein somewhere.
And what's about its relationship to breast cancer?
There is a relationship. So processed soya is directly related to the high incidence of breast cancer. So it just on the estrogen receptors, it goes and affects there. So soya should not be used, especially processed soya should not be used in diet at all. And you should discourage patients to have soya chop especially.
Dr. Sanyal, I can't see there is one question for him, but meanwhile, I'd like to mention that there are 1,215 people in the audience today, and their 100% response is that they want more discussion on this topic. Dr. Gordas may kindly note.
Yeah, I think we need to now take the next webinar a level higher, a notch higher, and we have to touch upon the issues that we have left uncovered. I think we identified a few aspects of diet. I think, Ashish, you really set the ball rolling. I think we were a little too rigid with the time because that area had too much to be covered, and I think we'll have to have you back. We have to look at intermittent fasting, so different types of eating habits. See, we today touched only about diets, but we didn't talk about eating habits except about snacking in general, okay? I think that that's a very important issue, the timing of food and so on and so forth. And I think we have to look at different forms of exercise. I think Charles dealt with a few. Actually, I have a few, shall we say, YouTube links, which I thought I'll share with you, but I can do it next time. And I think Kaushal and I and Arun have to work very hard on the yoga front to put up what is the actual data and how it works. I mean, there's no doubt that if you look at Baba Ramdev, whether you like him or hate him, he doesn't have fatty liver disease. You can see by just looking at him. And the fact of the matter is that he has popularized yoga, even if you don't agree with the rest of his stuff. So yoga does obviously have a place, and especially in Indian minds. And we have to be able to remove the grains from the chaff and put it across.
Gaur, another...
Dr. Sanyal,
yeah.
ask his question.
Yoga, Yogesh, yes, you were saying something.
Yeah. A couple of things which I thought also need discussion next time is the role of coffee, role of green tea, and these particular aspects. Intermittent fasting certainly is very important. And as snacks, I think chanas are excellent. No calories. If one can be a proponent of that, as long as one can have.
Yeah. I'm surprised Aileen or Anjali didn't mention cucumber. Actually, cucumber is often served as snacks, even with drinks. I think it's a very low calorie stuff, which is pretty good.
Very true.
Arun, any suggestions from you?
There's one question for Dr. Sanyal. How much sleep is recommended daily, and what does one do if he cannot get that much sleep?
Well, I mean, you're screwed.
Let me ask you, what are you doing?
I'm neither God nor a magician. I'm just
What are you doing with your lack of sleep?
So physiologically, you need between 6 and 8 hours of sleep. you really should not drop below 6, you know. And the reality is staying up till 2 o'clock watching the news or doing stupid nonsense on Twitter or Instagram and all this rubbish that actually has created a whole new problem of adult onset attention deficit disorder in our general population, you know, and is actually, in my view, this is an untested hypothesis, that a lot of the increase in mental health issues that you're seeing in society are driven because we are not disconnecting. The brain, like everything else, periodically needs to disconnect and reset itself, you know, and which is why people have hair trigger tempers, things set them off, because and these are all interrelated and interconnected problems. I think if somebody tells you that they are unable, there's some real limitation to them getting enough sleep. It requires a more detailed conversation about why that is so. And, you know, how much time are they spending doing email with their buddies, or email is now considered, my children tell me that's very old fashioned, that no one does email, that, you know, you have 10 other things on their cell phone that they are doing. And I keep telling them that that's the reason that they are so stupid, because they don't actually know anything, because their entire body of knowledge is the gossip they hear on a daily basis. So, you know, I'm ranting like an old man, but that's what I am.
Can I just add one little thing that I tell all my patients to meditate. I think it is something which patients find very non-doctoral, but I make sure that everybody, I give one link of meditation, so that because of the high stress, that is one thing that really helps, and there are a lot of studies, as you all must all know.
We're actually conducting.
Which is the link that you, link that you give? Headspace?
No, I give a link on YouTube, which is, you know, it's a basically 20-minute thing that you listen before you sleep. It's like a chakra balancing. It's just concentration. It's guided meditation, basically. Guided is initiative.
So the other emerging field is mindfulness.
Yeah. And
we're actually conducting a international trial, US and Denmark, on a mindfulness. It's a more holistic approach to managing fatty liver disease without drugs, but specifically focusing on the concept of mindfulness. And it's 20 minutes per day, you know, and it's again a guided approach, and you do a certain number of things with a coach, and then you do it by yourself, then you regroup with your peer group. And so there's a whole set of structure, because, you know, you can't just tell somebody to be mindful and then ask them to come back 3 months later because nothing will change. So it's a process. So, you know, I think this is a huge untapped area. And the beauty of this area is that you can impact diabetes, heart disease, cancer, so many things, and general feeling of well-being and happiness. Because in the end, you know, good health is not the absence. You know, I in my old age, I understand this, because that used to be the WHO definition, right? That health is a positive construct. It's not just the absence of disease. And frequently we focus mainly on just making a person disease-free, but you can actually do better. And I think all of these things we're talking about together will have to be combined with social messaging, so that on the importance of living more healthy, taking time for yourself, you know, shutting down periodically, resetting your brain, being more thoughtful, being more mindful. It'll actually make society better. But it's not a simple process, as you can imagine, but worthy of discussion.
Sir, Dr. Chawla, sir, and Dr. Madan, do you have any questions?
No, I think there was a question on the type of aerobic and resistance exercises. Gaur has mentioned it could be done next time. And for Charles, difference between moderate and vigorous, what is the definition of these exercises?
Do I have time to show 1 or 2 slides? I'll make my presentation next time, but just to give a kind of a appetizer, if you're interested, I can show that.
Yeah, sure.
I'll just as an appetizer, okay?
Right.
Can I have the next third slide? Not the. Go ahead. Yeah. Next.
First 4, 3. All right, side steps. Step out again. Here we go. A little bit wider now. A little bit wider than the first time.
So that I think many of you know, that's a very standard walk with Leslie. There are at least 30 versions of it. Next, please. Next slide, please.
4, 3. All right.
Next slide. Yeah. Now, there are other fitness links which I actually use when I nowadays write my prescription. So I give them a link and I ask them to open the link in the OPD before they have gone home, so that if they have a problem, and then I encourage them to do that. Next, please.
Side, come back to the center, bring up that knee and curl. Come back down.
So the point I was trying to make is that it's not enough to write.
So if you want to, this is another one that you can either add weights to it, or you can bump up the cardio challenge by actually doing a jumping jack in between.
Depending on the age and their fitness.
Choose.
Next, please. Okay, now this is Surya Namaskar, and the one on the left, can I have that playing, please? That actually shows Surya Namaskar being done in Japan. Okay. Next, please. Yeah, so you can't ignore Baba Ramdev when it comes to yoga, but there are quite a few links. So basically what I do, and Anjali, I'll take your opinion on that. I ask the patient, what is your mindset like? If it's one of those South Delhi westernized type, they would probably like one of those white-skinned guys doing a lovely exercise, walk with Leslie or something like that. I give them a link like that. When it comes to my Lucknow practice, they think that this is too foreign. So then, I give them one of the yoga links, which are, I think, equally effective. So never mind the color, never mind the format, as long as it delivers results, But I make it. Yeah, go ahead. You were telling something.
No, I was saying there are a few apps that you can share with patients, because
that's exactly what
Google
I do.
Play also, yeah.
Yeah, and I share it with the patient nowadays in my prescription. I have the link mentioned there so that they have to just click on it. And I also have a few diet links. And that actually, I'm doing a survey now to see that if I have advised it to 200 people, how many have actually followed it. And some of the stories are remarkable. I mean, people have lost 10 to 15 kgs and they have learned how to feel wonderful and healthy. Next, please. Yeah, I think that's the feedback form. I have to just remind you that whatever we do, it's based on your feedback. Do spend half a minute to give us a feedback. And it was a pleasure having you over from my side. I have to thank the chairpersons and the speakers, Yogesh and Anil and Kaushal. And over to you people to thank the speakers, and then Kaushal, and then our organizing secretary, Dr. Rinkesh.
Dr. Chawla, you can begin by thanking.
Yeah, I think it was a wonderful exercise today, Gaur. As usual, this has been a wonderful series. As you said, we learned a lot today on diet and exercise and NAFLD, but we still have a long way to go, and maybe in the coming series of talks, we would learn more. So it was
I might as well announce, I was planning to have the Indian NAFLD as the next one, but if suppose the demand for diet and exercise and lifestyle is overwhelming, we could possibly have this continued over to the next one. So we'll go by what the feedback is.
Right. And extremely grateful to the speakers who took us through all these talks, especially Ashish, Dr. Eileen, then Dr. Anjali and Arun Sanyal. So it was extremely wonderful listening to you all, and we learned a lot. Thank you very much, Arun, for joining us very early in the morning. But without you, we cannot have a symposium on NAFLD. Over to God.
Thank you. I thought the talks were fantastic. All of the talks, I really enjoyed it. And I think many common themes emerged. So, when you start distilling through all the different perspectives, I think when you start hearing some common themes emerge, then you know that those are things that you can actually bring into your practice. And I think the points made by Eileen, by Anjali, by Charles, and then Ashish's beautiful exposition of all of the data. Unfortunately, I missed everything because of the time gap, we had a little bit of a screw up. So when I joined, I missed the early part of the things, but everything I heard was really fantastic. And we covered a lot of ground, but as you noted, there's a lot still to be done. And I think this is the next frontier of NASH research. The drugs will come when they will come, but this is really where I think there is, and it's a level playing field, right? Because nobody knows how to approach the complexity of all of these things. So I'm looking forward to the next session.
Thank you, Arun. Make sure you're there on time next time.
ठीक है.
No, we'll bank on you.
Yeah, thank you, everyone. So we invite you on behalf of Hope Initiative and INASL for the next webinar on 13th of December 2020. And yes, based on your feedback, we'll decide whether the topic will be Indian NAFLD, is it unique, or we want to continue more discussion on the lifestyle interventions. So with that, I'll hand it over to Rinkesh to give a vote of thanks.
My sincere thanks to all the wonderful speakers as well as our eminent chairpersons. Thanks a lot to all the delegates who enjoyed. I hope they enjoyed very well. Our next webinar, which is the last one, is on 13th December. So kindly just lock it. And your feedback is very important. So please fill your feedback and return to us. I want to say thanks to all the organizing team members, advisor and executive committee members. I also want to thank Zydus Bionext for the educational grant and our Swarnim Touch, which is event partner. Thanks a lot. We'll meet on 13th December, 4:30 p.m. onwards. Thank you very much.
Thank you. Thank you, Arun.
Bye, guys.
Thank you.
Bye-bye. Bye. Thank you, Charles.
Thank you, sir. Thank you.
Thanks a lot. Bye.
Thank you. Bye.
Bye-bye.